Welcome to another episode of Let's Talk Health. I am your host, Casey Ricks.
I'm Dr. Shannon Ricks, family nurse practitioner. Today our topic is addressing healthcare disparity of maternal mortality rates among Black women.
And today's presenter is the very hilarious Dr. Krystal Thompson. Dr. Thompson, we are definitely glad that you have volunteered to be with us on today. Can you take a few minutes to introduce yourself to our guests?
Sure. I am Dr. Krystal Thompson. I work in New York State. I'm in Binghamton, New York, and I am an OBGYN, a generalist. I am a proud product of Christian education. I went to Christian school throughout my training. Then I went to Oakwood for college, which is how I know Casey.
All right.
Class of 2005.
2005, baby. OU, OC, when we were there.
And from there, I went to Meharry Medical College, which is where I did medical school, and I did my residency in OBGYN. And so now I'm out practicing.
All right. And you're practicing in New York, you said, right?
State. Mm-hmm.
All right. Saving lives. So we're going to go ahead and get started with our first question. So Dr. Thompson, this is a very important topic. In fact, I didn't really know this was an issue until about maybe 3 years ago when I saw it on the news and they were doing a report on it. And I didn't know that this was an issue. I know racism is definitely in the healthcare system, but I didn't know that this was an issue. So what is the maternal mortality rate among Black women?
Okay, so first I'll define maternal mortality. So what is maternal mortality? It's the death of a woman either during her pregnancy, during her delivery, or in the short time after her delivery, the 6-week postpartum. So anywhere in that time frame, any death related to the pregnancy or the management of that pregnancy is maternal mortality. And the numbers are pretty astounding in the United States because the Black maternal mortality rate is 3 times that of a white or Hispanic woman. And even worse, when you're 30 and older, which is me, the maternity mortality rate increases to 4 to 5 times.
Oh, wow.
Of a white or Hispanic woman. So that's why this topic is so important and is being discussed so frequently. And also, of those deaths, 60% are preventable. 60%.
Wow.
That's why we're trying to figure out what the biases are or what the problem is and what we can address to lower this rate of mortality.
Yeah, and that's a little concerning. 60% are presentable. So what are some of those causes of such a high mortality rate among Black women?
Well, for one, we come into pregnancy with chronic illnesses. So goes to hypertension, to diabetes, higher BMIs, kidney disease, heart disease. So these are some things, and the actual deaths are due to high blood pressure, increased bleeding, postpartum hemorrhage. So yeah, these are things that we are predisposed to that we should address prior to our pregnancies. But those are some of the risks for Black women.
So you said a little while ago, I wanted to follow up on something. You said a little while ago, those over 30, it increases. Why is that? Why is it increased with age?
I think it just increases with age because you're not as young and able to bounce back. With our younger patients, sometimes they have complications, but because they're so young, it's easier for them to recover. The older you get, it's a little bit harder to recover. Like we'll have patients who have a massive blood loss and they're like 18, 19, they'll regain that blood and they'll find like nothing ever happened. But the older you get, it's a little harder to recover from those incidents. And birth is a major thing. To deliver a baby, to be pregnant, a baby is a big deal. Like your body is going through a major stress on your body. So it's something the recovery is important and pregnancy is important. And it's a blessing to be pregnant, make it to the end of your pregnancy, deliver a baby, and be fine. That's a blessing because pregnancy is stressful on a woman's body. So
yeah, one of my friends told me that the doctor told them that giving birth for a woman is the closest she would ever be to death. Now, is that true?
I mean, I would say that it's a major thing. A vaginal delivery, C-section is a major surgery. So yeah, I would say that it's women are strong.
Yeah, yeah, that's the reason why the Lord did what He did.
I want to see a man have a contraction so bad.
You said what again?
See a man have a contraction so
No,
bad.
you don't. No, you don't. No, you do not. We good. The Lord set it up the way He did for a reason. So, research studies show that chronic diseases are less controlled in Black women. Can you explain the importance of access to quality of care, specialist providers during preconception, pregnancy, and postpartum impact on health?
Yeah, so having chronic illnesses in pregnancy, so it's important to see a specialist prior to becoming pregnant. So when you have these preconception visits where you see your specialist, you have a primary care doctor that you see regularly, frequently, you can get your chronic illnesses under control prior to your pregnancy. As I stated, pregnancy is a stressor on the body. So if you come into the pregnancy with your blood pressure out of control, your blood sugars out of control, weight, excess weight, all those things that you should manage prior to your pregnancy, it increases the risk of having what's the word I'm looking for, of having a high risk pregnancy. So it's important to see your doctor and get all those things. You want to start your pregnancy in optimum health if possible. You want to do the weight loss before you get pregnant. You want to get your sugars under control and get your body in a healthy state for the pregnancy. So that's why it's important to see your doctors beforehand, so that when you're starting out, you know, you're in optimal health. Also, what's interesting is that 50% of pregnancies are unplanned. And unplanned pregnancies have a higher risk of negative outcomes. So if you're seeing your doctors and everything before you get pregnant, you can kind of plan your pregnancy. You can do family planning if you want to start contraception, any form of birth control, however you want, so that you can manage your chronic illnesses before you get pregnant. You can kind of time your pregnancy. You can say, okay, I'm going to get my sugars, everything under control, then I'll get pregnant. So you can kind of plan ahead instead of having this unplanned pregnancy, and now you have additional stress and you're behind the ball kind of. So it's important for getting everything under control and for helping to plan ahead to decide when it is that you do want to have a child.
Okay. So, and that's during pregnancy and postpartum as well, or well.
You should still be seeing your doctors, because even after your delivery, you should still be seeing your whatever doctor, your diabetes, whoever you're seeing for diabetes, for thyroid disorder, for heart disease. You keep seeing your doctors even after your delivery, and you keep in contact with them to make sure that after your pregnancy, your blood pressures don't go back up or things don't go back out of control. So you should keep in contact with your doctors. Some patients, when I see them, I'm the first primary doctor they've seen in years. They haven't seen anyone prior to me. So I'm kind of managing their diabetes. I'm managing their blood pressure. I'm managing everything. I'm the OBGYN, but I'm managing all kinds of things because they haven't seen a doctor in years, and I'm the only one that they know. I am their doctor for anything. They stub their toe, they call me. So OBGYN, you're kind of a primary care doctor because you are managing a little bit of everything for some patients who don't have an established doctor prior to the pregnancy.
Okay, so it would make sense that if you are planning on getting pregnant and you realize you have these health conditions, high blood pressure, diabetes, that will put you at risk, it would make sense for you to start addressing that issue right away before you go through the process of having a child, correct?
Yes, you want to kind of get those things under control and manage them before the pregnancy to give you a better chance of having a good outcome and having a healthy baby. So addressing these things before is optimal for optimal health and for optimal outcomes. So yes.
Okay, and I had one more question about during the pregnancy and the illness of diabetes and high blood pressure. During pregnancy, people that, and I don't even know what it's called, it's a name for it, but I can't think of it right now. We can get diabetes when you are pregnant, or high blood pressure.
Gestational diabetes or gestational hypertension.
Yes.
of high blood pressure when you're pregnant. So when you're pregnant, you have an OBGYN, so we will manage that. You're a generalist, I'm a generalist, and if the problem is out of hand, then we'll send you to a maternal fetal medicine doctor. That's a high-risk doctor who manages high-risk pregnancies. So once you are pregnant, you know, we'll manage that. I will manage all those things for you, but it's helpful to come into the pregnancy already having them managed, because the pregnancy is a stress on the body, so you're kind of chasing these things if you come in while pregnant. And for patients who have unplanned pregnancies, by the time they come in, they're already in their second trimester. They had no clue they were pregnant. They didn't plan for this pregnancy, so we're really kind of behind the ball. So prior to pregnancy is great if you can get it controlled. If not, when you are pregnant, I will manage it, and I will co-manage with a high-risk doctor, a maternal fetal medicine doctor who manages high-risk pregnancies and chronic illnesses in pregnancy.
How about nutritionists? If someone does have those issues, diabetes, high blood pressure, should they hire a nutritionist or go see a nutritionist or dietitian?
So we will give, as the OBGYN, we'll give basic information about nutrition, but there are trained nutritionists who we refer patients to help with management of the patients, with their diabetes and diet or whatever. So we do use trained nutritionists for our patients.
Okay, good.
All right, so the impact of racial bias and patient-provider interaction, treatment decision, patient adherence to recommended actions, and patient outcomes has been a proposed factor or factors throughout research. So what are some crucial conversations that we need to have with our providers during the preconception, pregnancy, and postpartum?
That is a good question. So I would say to get a doctor, before all of that, make sure you get a doctor who you feel comfortable asking any question to, who you can communicate with. I have a lot of patients who have negative experiences in their pregnancy because they never formed a relationship with their OBGYN. If they have a question, they're afraid to ask because they think the doctor will brush it off or, you know, talk down to them condescendingly. They might not understand what preeclampsia means or different things, and they don't want to ask. So there's no communication between a doctor and patient, and so it's less likely for those patients to adhere to the recommendations because they don't really trust that doctor. There's no relationship there. So I would first say get a doctor that you feel comfortable with, kind of shop around and figure out who it is that you feel understands your culture, understands you as a woman, and who you can communicate anything to. And some important questions to ask in those visits are things about pregnancy. Like a lot of women, they don't know what pain management is in pregnancy. What are your options for pain? Some women, they know a lot of, or they've heard a lot of rumors about epidurals and the side effects and the outcomes. So you can ask questions about your pain control, whether you want epidural, IV pain control. It's so important to talk about postpartum with patients.
Mm-hmm.
We spent a lot of time talking about the pregnancy, and we build up 40 weeks, the baby comes out, boom, and in 24 hours, you're out the door, and
that's it. The conversation ends.
In 6 weeks, now you're a month and a half by yourself, and the postpartum body is a totally different body than before you were pregnant. Your skin changes, your hair is falling out, your mood changes, your appetite changes, your diet changes, your interests change, all the friends you had, they know where to be found, and you know, like your whole life kind of changes, and you're just out by yourself for 6 weeks. That's the next time you see a doctor. So it's important to talk to your doctor about the postpartum period equally as you should about the actual pregnancy, because that 6 week frame is you can develop preeclampsia after your pregnancy.
Yeah.
And after your pregnancy, you can get preeclampsia, your diabetes can worsen. So the baby coming out isn't the end. That critical part after, a lot of things can happen to your body. So that's an important conversation that I have to remind myself to talk more about the postpartum phase with my patients, because they'll call
Oh, sorry, you can go ahead. Okay.
Sorry, they'll call me with questions like, and they're normal things for postpartum, but it's scary for a patient who doesn't know that they should expect those changes. So I'm sorry, what were you going to say?
No, so like I've read a lot too, that within the first year out even, you're at high risk of developing, blood clots, post epidurals, issues that people just get dropped off and don't know what to do, and they had all these problems post epidural 6 months out. So like, can you give an example of how to approach those things too? Because it can happen even up to a year post, you know, and sometimes in primary care, we don't know all of the little things that happen. So how do we help y'all?
That kind of plays into the part where I said you should keep in contact with your specialist even after. So after your pregnancy, if you have a question, make an appointment, go see a doctor. You don't have to wait till your pap smear a year, 3 years from now for the next time for you to see a doctor.
Mm-hmm.
Your body, you know when something is just not right and it's off. Make an appointment, go see a doctor. Don't be ashamed to go see someone. Don't wait for a whole year. If you feel changes happening, go see a doctor. If you can't get control of your blood pressure, go see your primary care doctor. If you're having pains in your back that since your epidural and it's 6 months out, maybe you need to go see a neurologist, someone to take a look at your spine. Like, stay in contact with doctors in that postpartum period. If you feel something, say something. You know your body, and it's okay to speak up. Call your OBGYN and say, since my delivery, I've had this whatever issue, this headache or this discharge or whatever, and speak up. So be an advocate for yourself. Do not be afraid to speak up for yourself. You have to be an advocate for your body. And if something is not right, you make those appointments. See someone.
So real quick question. What if they are being, and I think this from what I have read and have seen, what if their concerns are being ignored by that doctor?
Get a second opinion. If you ask me a question and you feel like I'm brushing you off, I would say get a second opinion, get a third opinion. There are many doctors. If one doctor does not cater to you, there's something called firing. You can fire your doctor. You know, and you can move on and try to find someone else who you feel comfortable, who you can communicate with. So I would say get another opinion. One opinion is not enough. If you feel like you're not being, if you know something's not right and someone's ignoring you, say something. Speak up. You
Okay.
can.
Okay.
Good. So we also found research that shows that access to quality of care, and not only access, but also, as you discussed, the specialist providers. But then we also have systemic factors. We also have community factors like securing transportation for medical visits, inadequate housing issues, and facilities being prepared to provide the specialized care, or even care, period, for those who are pregnant, are also big factors that can improve outcomes. How can we address these issues in preconception, pregnancy, and postpartum?
So that's a hard one, because that's something that requires not just doctors, but that's like a whole systemic.
Mm-hmm.
That's systemic racism. You just define systemic racism, not having the access and the resources. And so, yeah, we see that a lot. I have a lot of patients who are underserved, live in rural areas or urban areas. I hate that word, but urban areas. And facilities there are not as nice as for your private patients in the suburbs or whatever. You have facilities where you're in the lobby and all these patients are trying to see one doctor, and you have 2 doctors and 100 patients in the lobby.
Mm-hmm.
They don't have any time to sit down and talk to you and explain anything, because they have 60 patients to see in 4 hours. So it's just kind of like in and out, and you don't really get to connect. A lot of these clinics are in places that are not on a major transportation line. So for patients who have unreliable transportation, they're unable to get there, so they miss appointments. All these systemic factors play a role in prenatal care. So if you're missing appointments, we're missing things. If something is happening, we're missing it, and by the time we get to it, it's kind of late. So this is where funding and the people who you vote into office, stuff like that happen. That's where you need to speak up, because we need advocates in places where there isn't any advocacy. We need resources in these places. So there are many factors. This is where we need to speak with our legislators, and this is when local elections become important. You need to people who actually care about your local community. We're so quick to worry if you're going to vote for Trump versus Biden. You need to be worried about your local election. We need to be advocating for you. I know I was reading that in Kentucky, I'm probably going to say her name wrong, Attica Stone, I think her name is. She's like the only Black female legislator in Kentucky, and she's pushing really hard for reform for maternal, Black maternal mortality. So you have to have people who look like you sitting at the table to help make changes and resources into these areas, because if they don't have the resources, it's kind of hard to help. It's easy to say, oh, go to a better clinic, but how are they going to get to this? How are they going to get across town to somewhere that does not accept their insurance? Some of these people, they're like, oh, you can't bring your kids to the office. If you're the sole provider for your family and you're the only parent, who's going to babysit the kids if you can't bring the kids to the office? So you're just not going to go. So a lot of these social factors need to be addressed in this, when we need advocates, legislators, and people to advocate for our communities and bring resources in. Bring more doctors in, so there's not so many doctors seeing all these patients, and there's more time to spend with the patients. So yeah, it's a whole systemic thing that we all need to work in different aspects to bring change. So I would definitely say be harder on be involved in your local elections, and hard on your legislators and people passing laws.
That's vitally important. I don't think people put enough emphasis on the importance of those local elections. I think I'm hoping it's starting to turn around because of it's being addressed, but local elections are vitally important to a lot of issues that we're dealing with, and that impacts us on a daily basis.
We need people to run for these offices who look like us. We keep saying we want to change these things, but we don't have any representation. Like Attica Stone in Kentucky, she's the only Black woman. So it's just her. So we need to kind of run for these offices and be in the mix for the decisions that are being made. So even doctors, we have minority doctors are like a very so we need more Black doctors, Hispanic doctors, doctors who are culturally competent and aware. And so I think that also will help with this whole mortality rate.
Yes. So research suggests that location matters. Sizable portions of racial and ethnic disparities in severe maternal morbidity and mortality may be explained by variation in hospital quality. Racial and ethnic minority women deliver in different and lower quality hospitals than white women. What should women look for in the delivery phase of care?
The delivery phase. Okay, so I would say, for one, to know your hospital. So I encourage patients to do a tour. So you can go to labor and delivery, and you can do a tour of the labor unit. You can see what the labor rooms look like, what your options are, whether it's a birthing club, or just kind of know what kind of facility you'll be delivering in. Also, I would say, see if your hospital or if any of the health departments in your area have birthing classes. So birthing classes are important. You get to learn about your anatomy, your body. You get to understand the changes that happen to your body during your pregnancy. You understand the stages of labor, what to expect when you're going into the hospital. They speak about kind of mind control and being in control of your body, Lamaze classes, breastfeeding classes, so that when the baby comes and when you're in labor, everything isn't brand new and you know. So I would say look up birthing classes, look up the facility that you're going to deliver in, look into it, see if you can bring a doula with you. Studies are showing that now that doulas are helpful with Black women, because a lot of Black women go into labor with so much anxiety because of the mortality rate. So they just go into the process very tense. And a doula is pretty much an advocate for the mother. So she'll make sure that you're comfortable, that your concerns are addressed. They kind of, they're like a coach, a birthing coach. So see if you can bring a doula with you. Speak about pain management. What are the options for pain management in your delivery? Black women, I know you see the slogan a lot, believe Black women, but people think that Black women can take a lot of pain. So they allow us to be in pain and labor and say, no, you're fine, you're okay. And pain management has been an issue for a lot of women. So that's something you can address to see like how early you can get an epidural if you want one. Just kind of see how the facility manages labor. You can do a tour and ask these types of questions beforehand. If you want to have a midwife, does the hospital allow you to? Do they have midwives that deliver at that hospital, if it's something you want to do. If you want to manage your pregnancy. So yeah, these are things you ask for the delivery phase.
Okay. What are hospitals doing to address this issue?
I know a lot of states are putting together a task force to address the mortality rate. So the thing is, there's no one being held accountable. So all these people are dying. All these people are dying. And that's, do you hear feedback?
Yeah, we hear feedback.
The task force will have, so if someone dies, a team gets together, the pharmacist, the doctor, the anesthesiologist, the nurses, and everyone discusses where the ball dropped in this person's delivery. What did we do? What sign did the patient give us that things were not right and we ignored it and we acted as if she was okay when she really wasn't? So each death has to be looked at together with the team to see what we did wrong, how we can not let that ever happen again. So they're putting together a task force to do that. They are doulas and midwives, for instance. Medicaid is starting to cover those options, so that women have broader options than just coming into the hospital. Some women don't want to deliver in the hospital, and they're forced into facilities where there is a high disparity rate. So now they're offering coverage for more options. What else are we doing in the hospitals? Oh, they're doing implicit bias training. The doctors, the nurses, the medical students, the residents, they're starting training where you have to go to implicit bias training and in services. And it's funny because when you hear implicit bias, you assume that it's a white person who has biases against a Black person. There's implicit bias between Black people. Like just don't because your doctor is Black that you're good to go. Like there's no bias. We have biases, people from the South versus people from the North, people from America versus people who are not from America. Like there are biases within our own race. So implicit bias training isn't a white Black thing. Everyone is being trained, it's being addressed for everyone. You can't assume that because someone looks like you that there is no bias there. So that's another thing they're doing as well. Mandatory implicit bias training. So,
and I'm glad you hit on that about just because it's a Black doctor doesn't mean that they are gonna be good or whatever, and they don't have any biases, because a lot of times we think, oh, we gotta go get a Black doctor, so I'll be good. But you know, Black doctors, like you just said, has other biases as well. So what in the case of you should follow the same guideline if you have a Black doctor that has, you realize, a bias as you do a white doctor?
Ask the questions. You can even directly ask, like, what is your stance on maternal mortality? Like, do you see an issue with that? Have you read up on it? And if they're like, if they have no idea what you're talking about, that's probably a red flag that you want to kind of shop around a little bit more. If they don't even see that that's a problem or that it needs to be addressed, or are looking for ways to fix it, then that's probably a red flag that you want to look for someone who knows that there is a 3 to 4 greater chance for mortality just based on you being, on the disparities in race. And that's something that they should be actively looking out for and to address. So yeah, so if you find a Black doctor and they, you can't communicate with them, or you're telling them, your fears or your issues, and they're gaslighting, like, no, it's all in your mind. I've seen it. I had a patient this week, actually. She had a delivery and she's in her room. I did her delivery and I left. So they called me and said, oh, she's having a little bit of bleeding. I said, okay, give her a little medication and see if it helps. So next thing I got a call, like, oh, the bleeding has gotten worse. So I come in and everyone is just standing around her. And this lady's like screaming out in pain. And she's like, something is not right with me. No one is listening to me. You guys aren't taking me seriously. And this nurse is rubbing her on her arm like, no, you're okay. It's all in your mind. Think of something positive. And I'm like, wait. So when I actually assessed her, this lady was having bleeding. Like she was bleeding inside. Body was filling up with blood. She was having postpartum hemorrhage. I ended up having to take her to the operating room. And she did fine. She did absolutely fine. She went home the next day. But telling a Black woman that she's not, or any woman, telling a woman who's in pain that they're not in pain, that's gaslighting. You can't tell someone, no. They literally looked the lady, she's screaming at the top of her lungs, and the lady's like, you're okay. Just think about going to the beach. And I'm like, you can't tell someone that. So you need to be surrounded by people who will listen to you, who you know will take you seriously, and who will address your concerns. So that's part of getting to know a doctor. If you when you're shopping for a doctor, have that conversation like, doc, you know, if I have a concern, will you address it? You know, how do you feel about pain control or whatever? Those are questions you ask a doctor. And it's okay to say, you know, I like you as a doctor, but I don't think you'll be the doctor for me for my delivery. And you have the option to pick who you want. So
in other words, we need more doctors like Dr. Krystal Thompson. That's what we need.
I want everyone to live. I want these babies to go home with their mother. I just, you know.
Yeah.
It doesn't take much. Sometimes you just have to put yourself, say, how would I want someone to manage my mother? How would I want someone to manage my sister? If it was me in labor, how would I want someone to manage me? And I use that a lot for the way I manage my patients. I put myself in their shoes. I've never had a child, but if I were in this position, you know, what would I want? Would I want someone to listen to me? Would I want someone to tell me if I'm screaming that I'm about to die and you're like, you're okay? Like, you know, I would not want that to happen to me. So a lot of times in medicine, it just takes that. And with this patient, she did so well. She hugged me about 20 times afterwards. She was like,
wow,
so much. I really thought I was going to die. And when you looked me in the eye, I knew you got me. I knew you had me. And I took care of her. And she went home with her baby. She did fine. But sometimes it just takes you humanizing yourself, putting yourself in that person's shoes, imagining that was somebody that is related to you. And how would you want your family member managed? And a little empathy and a little bit of humanity goes a very long way.
So I read, and I'm going, before I go to my next question, I read about doctors, and they did some study or something like that in medical school, and I'm pretty sure it's in with OBGYNs as well, that where doctors believe the foolishness that Black people can handle more pain than normal people. Have you ever heard of that?
And I don't know who came up with that. I don't know. It's that whole strong Black woman thing. I don't. I've heard that, but I don't believe that. Pain is pain, and everyone's tolerance to pain is different. What you can tolerate, what your wife can tolerate, what I can tolerate, all three of us have different thresholds for pain. So you can't look at a race of a woman and decide what her pain tolerance is. That's ridiculous. So that's
yeah, when I read it, I was like, that's just straight up sound like somebody looking for an excuse to not do their job or to do something because.
Let me let you know, when I ask for my epidural, please give it to me. Don't tell me I'm strong and I'm not good. Please help me.
Yeah.
So if you know, people know their body. So if they ask for something, they're not just making it up. Like you know your body. So
yeah.
That freedom.
Yeah. So does one's economic status make a difference in treatment? I know you hit on this a little while ago. Does one's economic status make a difference in treatment and mortality rate?
In treatment, maybe, because you might have better insurance. And mortality rate, no. The mortality rate goes across the board, no matter your education, no matter your geographic location, no matter as Black women, our mortality rate is elevated, period. Actually, it says that for women who have college degrees and higher, their mortality rate is like even higher, like 5 times that of a white woman who has less than a college.
Wow.
It was. I read it on the CDC website. Like the being more educated, for some reason, the risk was even higher. So no, absolutely not. Having more education, more money, living in a gated community does not make you exempt from the maternal mortality rate. So no.
All right. Great.
All right. So what are some large scale initiatives that we can address that addresses this issue? How can we be supportive of large scale initiatives?
So I was kind of looking some of those things up. I kind of mentioned them earlier, like this task force recommendations. So ways that we can address them, I would say, for one, like I said, try to get involved in the things that happen in your local community. Go to your town hall meetings, get to know who is making the decisions in the hospital, who is the hospital CEO, who are your advocates, does anyone look like you who is in leadership, and try to get someone into the leadership positions who is culturally competent and who will fight for to lessen this disparity, this racial disparity. I know a lot of local communities, they do health fairs where they'll invite the doctors from the hospitals so that you can kind of get to know your healthcare workers, your nurses, your nurse practitioners on a outside of their white coat, outside of the hospital. And you kind of get to, you know, make that community connection. This is about community. The mortality rate for anyone should scare everyone. So we should all community be interested in making sure that every mother gets to leave the hospital with their baby, and the baby has a mother to grow up with. So I would say get to know your local officials, do community service, do health fairs, invite your doctors. Like I know my dad's church, we try to invite a high-risk doctor to come and speak to the church, and we'll invite the community to come so that they can ask questions. Invite an anesthesiologist one week, invite a pharmacist, so you can kind of bring the doctors to the community in a less stressful environment than when they're in the clinic and they have 50 patients waiting in the lobby, so they're kind of, you know, rushing. So you can kind of meet your healthcare workers and your officials on a local community, casual environment, and get to ask questions and get to know people like that as well. That helps to make the physician-patient relationship stronger as well. So I would say to do that. And then it's funny, on social media, I have Instagram, and if you look up the hashtag Black maternal mortality, just the hashtag alone, you'll see so many initiatives from different states, because it's hard to say. I live in New York, so it's hard to say what the initiatives are in Tennessee or California or Wisconsin or wherever. But if you can look up stuff like this. Like, if literally, I looked on the Black maternal mortality hashtag, you can just mix the words up: Black maternal health, Black mamas, and there's so many different things you can find. You can use social media to learn about so much. It's an amazing resource if used for the right reason. And so you can kind of look up what's going on in your state and see what proposals there are that you can, when you're voting, you'll know what you're looking for on the ballot, what initiatives to support. So it takes a lot of, it takes us being proactive. Sometimes you have to go look for these things and look them up, because it's not always going to be, you're not going to turn a TV on and they say, you know, this is that. Sometimes you have to research things for yourself. So I would say use social media, use hashtags, and kind of look up what bills are on the table, or things that need to be passed, and kind of support them and support those people. And again, get community.
Very important. I can imagine community is important.
Mm-hmm. Well, that was great. Great. Thank you so much. You've enlightened us all.
Yeah. Thanks, Dr. Thanks, Dr. Thompson. Baby, you was finished. I'm sorry I interrupted you.
You're fine.
Yeah. Thank Dr. Krystal. Well, Dr. Thompson, don't want to disrespect you.
Well,
we call you Krystal since Oakwood.
Invited to the community functions in Krystal. Get to know regular on a local level.
Yeah.
I said, when I get invited to community functions to get to know the community and like talk to the teams and all that kind of stuff, I said, I introduce myself as Krystal. I mean, they know I'm a doctor, but sometimes you have to speak to people on a very relaxed level, and it makes them more comfortable. They're more comfortable having that one-on-one, let's just talk, woman to woman, let's talk about this.
Yeah.
And so
a lot of
your white coat and just kind of relax and be, you know.
I know a lot of times when we do community initiatives at our church, when you have that one-on-one, when people feel relaxed and they have that one-on-one with someone, with a doctor or whoever, it's like they ask questions that they probably would not have asked their doctor, whatever the case may be. So I can understand that it's very important.
Absolutely. And it strengthens the relationship, and it makes you realize that I'm a doctor, but I'm a Black woman. Like, I have the same issues you have. I also suffer from systemic racism. There's racism in medicine. Like, the more you speak to people, the more I speak to the community, the more they realize there's really not that much separation between us. I might have a different degree than you, but we have a lot in common. So sometimes we have to not let the letters at the back of our name and our degrees separate us too much from the community. We have a lot in common. We have family members. We have mothers and aunts and grandmothers as well. So I think that community connection is important to decrease the disparity and to increase the relationship between your healthcare providers and your patients.
All right. Again, Dr. Krystal Thompson, graduate of Oakwood College, now University. HBCU. We're definitely glad that you joined us, and we appreciate you, man. This was very enlightening. I learned something, and let me say this, men need to know this stuff as well, not just the woman, but the man needs to know this stuff as well, because we need to be beside our wives during this whole process.
Women need advocacy in pregnancy, and a lot of times their spouse is that advocate. So yeah, I would say that.
Yeah, so thank you again, Dr. Thompson, and thank you to our guests for watching another episode of Let's Talk Health.